Okay, so let's get started. So welcome everyone. My name is Tyler Plant. I'm Chief Revenue Officer at Simpli5, and I have the distinct pleasure of introducing our next session with our guest speaker, Marianne Roy, who shares our passion for improved collaborative patient care. She's helped numerous organizations reduce burnout, which Karen alluded to in her intro, which is a huge problem in healthcare. As well as other industries. But she's also helped improve employee and patient satisfaction. The number of healthcare organizations that she has helped is long and storied, and her work has garnered multiple awards and global recognition. She recognizes that effective participatory leadership is critical for better patient outcomes, clinical performance, and for the employee and professional satisfaction. Yet clinicians aren't typically taught these leadership practices. And so to address this gap, Marianne has been committed and has continued to working with organizations to create custom, evidence-based clinician leadership development programs. And she's here to tell us a little bit more about that. So please join me in welcoming Marianne Roy.
Great. Thank you, Tyler. And thank you, Karen, and everyone at Simpli5 for having this summit. I have been a big fan of 5 Dynamics for a long time. In fact, I'll give you a little bit of my background. I'm an organization development consultant. I do a lot with leadership development, and I do executive coaching, and I also have a practice around physician resilience and well-being. So I'm also Gestalt trained. So my first introduction to 5 Dynamics goes back to Mike Sturm at the Gestalt International Study Center, where I'm also faculty. So it's really interesting. For some reason, my 5 Dynamics profile isn't coming up. I will tell you what it is. Explore plus, effortless plus, and explore. I am deliberate in excite, examine deliberate plus, and deliberate plus in execute. So even putting together this presentation, I was doing my explore plus thing. Last Wednesday, the National Academy of Medicine rolled out their plan for health worker well-being. And based on that, I said, I've got to go back and redo this. So I'm actually going to go back a little bit to my roots. But I wanted to add 2 rhetorical questions for you to think about before I go on. Is one, what does patient-centered care mean to you? What does it mean to your family? And if you had the opportunity to build a patient-centered health system from the ground up, what would you do? What would it look like? Well, the South Central Foundation in Alaska actually had the opportunity to do that. In 1998, 1999, they actually took over responsibility for their own healthcare from the federal government, the Indian health system. The Alaska Native population has incredible health challenges. So in the 40 years that they've been at this, the South Central Foundation has won the Malcolm Baldrige Award, not once, but twice. I was really honored to be part of the 2011 award. I actually worked intensely with the South Central Foundation for 4 years. I commuted to Alaska in 2009, 2 weeks here, 2 weeks there. I live in New Hampshire. I moved to Alaska in 2011, was supposed to stay a year, stayed 2, and commuted for 2013, 2 weeks here and 2 weeks there. So it's been an actual, a highlight of my professional and personal life in many ways. So I just want to go back to say that, if anybody knows Don Berwick, he is the king of healthcare improvement. And he has actually said that the NUCA system of care is the worldwide model. So I ask myself, why isn't everybody doing this? They have actually a consulting branch now, and roughly 1,000 organizations have consulted with them, and that's out of 6,000 plus hospitals in the US. So it baffles me a little bit. I just had to show you what their campus looks like. It's gorgeous. If you've never been to Alaska, go. So, but their vision, one of the things about South Central Foundation, their mission, vision, values are palpable. So I wanted to take the first 15 minutes of this presentation to sort of make the work of the South Central Foundation come alive. Part of their vision is to have a Native community that enjoys physical, mental, emotional, and spiritual health. It is very holistic. It's the Native community. You can translate that if you're in healthcare, sort of a mega ACO, but it is really around the health and wellness of the Native community. The second part of their mission is working together with the Native community. And the operative word is together. It's not what healthcare providers can do to or for them. It is really, truly in partnership. This just gives you an idea of how large Alaska is, and the blue picture of Alaska with the pink is their area. Right now, they serve 65,000 they call customer owners and about 50 rural villages. So when you say, why pay attention to the South Central Foundation story, the numbers speak for themselves, and they have been able to maintain these numbers. And they've got all of the same challenges, if not more, than any healthcare system in the lower 48. What's their secret sauce? It is about relationship. Lynn talked about technical change versus adaptive change. She talked about relationships. Well, that is what they have been able to leverage. Traditional medicine is if we can diagnose you properly, figure out the right treatment, then we'll get to health outcome. The core belief at the South Central Foundation is that if we have better relationships, we will have healthier customer owners, healthier employees, and healthier organizations. I want to give a real example. So this is Frank. Frank is a patient, 79-year-old widower. He's got COPD, he's got heart failure, he's got diabetes. He lives alone. He's anxious. He's out of breath a lot. He phones his primary care office a lot. He's had a number of home visits over the last year. He's been taken to the emergency room on a number of occasions. He's had more than 7 hospitalizations. In our traditional healthcare system as it operates today, Frank's diagnosis is COPD, heart failure, diabetes. And if you look at his provider team, he's got a primary care physician, he's got a cardiologist, he's got a pulmonologist, and on. Yet Frank isn't getting any better. In fact, he is getting worse. And he's costing the system a whole lot of money. And the reality is nobody really knows Frank. So let's look at this from the NUCA, the South Central Foundation perspective. Their primary diagnosis is he's anxious, he's lonely and isolated, he's insecure. He doesn't have confidence around how to operate in this world since he's become a widow. COPD, heart failure, diabetes are his secondary diagnoses. And the interventions are a lot of personal care coordination, integration of care with the PCP team, figuring out what motivates Frank, what matters to him. And based on what matters to him, how can we come up with motivational interventions that will enable, empower, support Frank to take better care of himself. So it is a fundamentally different mental model. So when we look at traditional methods of how you manage workflow in a primary care office, this is how my primary care office works today, which advertises being a medical home. So you can see they've got preventive medicine, chronic disease, medication refill, acute complaints, test results. It all goes through the provider, and from there, it is filtered out to those who support the provider in this case, and that comprises my team. You can see that the provider can easily become overwhelmed. And trust me, in my practice working with physicians who are at risk of burnout, I don't know how they do it. So here is the workflow design at the South Central Foundation. So notice that the patient you can substitute for customer, that at every point in time, his team is working to the top of their license. In fact, at the bottom in the red is the healthcare support team. So if I joined this practice, I wouldn't just meet with my provider when I had my initial intake appointment. I would meet with this team. And they operate as a team. So when I joined the South Central Foundation, they brought me in as a consultant, I should say, I cut my teeth in teams in the medical device world. My first experience was in upstate New York with a manufacturing facility that made catheters. It was like being in school. Everything was operated by bells, when they went to the bathroom, when they went to lunch. And they wanted to convert to self-managed teams. That was back in the 80s. The rest of industry has taken off with self-managed teams. So part of what the South Central Foundation had the luxury of doing is they built a healthcare system from the ground up. And part of that is quite literally, they built a building around integrated care teams. So think about 4 floors, and on each floor, they have 3 of these pods, if you will, with an integrated care team. They all sit together. They all have very specific roles. So for me coming in, it was a wonderful learning laboratory because I could just go observe all these integrated care teams. And what they found when they first put people together, just that gave them a bump in health outcomes. But over time, things leveled out with a lot of the teams, and there were a few that continued to improve. So I was brought in to help them figure out what they were doing and then teach it to everybody else, and then have them become self-sustaining. So that was the work. And what we quickly realized is, one, the teams that were doing better, after a while, you could watch them. They talked together. And two, there was a real value around difference. They didn't have a name for it, but there was a respect for that. So I just want to talk for a minute about how this team is set up, because in reality, your care starts well before you go for a visit. This nurse RN case manager, I think of her as being sort of integrated care team central. She doesn't see patients face to face other than that first introduction. She is on the phone. She is the person who is really, she knows when I'm due for a mammogram. She knows when I'm due for a DEXA scan. She takes care of the panel. She sits next to this case manager support. That's the administrative person. That administrative person is trained to ask basic health questions. And if she doesn't know an answer, guess what? The RN case manager is right there. So she can say, hey, Tammy, does this person need to come in or not? Behavioral health consultant is there. Dietitians are there. So if I'm a patient and I am just receiving a diagnosis of cancer, well, the behavioral health consultant can come in and help me begin to process that. Sometimes it might even be the provider who talks with the behavioral health consultant to say, hey, how do I talk to this person, talk to this family? So based on these observations of these teams, we did a lot of interviews. I worked very closely. We had our own team of sort of figuring this out. So what we developed was a curriculum for these integrated health teams. Then we also created a team of mentors, coaches that support the teams because it's not a one and done. And one of the wonderful advantages we had is this thing called core concepts. Every employee at SCF goes through this, and it really teaches people about the basics of relationship, authentic relationship, sharing story from the heart, and basic communication skills. So it's actually incredibly rewarding to know that this curriculum is continued and continues to evolve, but it is very much at the heart of the success of integrated care teams. So if we look at, so what's the curriculum? It starts with self-awareness, 5 dynamics. Who am I? What is my preferred way of working? And the cycle of work, learning, collaboration is also really important. And it's kind of funny because it's really interesting to me because people love having the process, and automatically it helps people value other parts of the team. I'll talk about a pathology group that I'm working with now, but guess what? They're a bunch of examiners. And when they saw the cycle of work for the first time, that, hey, here's the natural process for getting work done, the light bulbs went off, like, oh, we need some of this around us. How do we get it? Then we work with the team graph. And again, it's all about the cycle of work, learning, and collaboration applied to teams, and how do they communicate. We did find doing some of basic team development work also helped. And we, in terms of the coaching, mentoring work that we did, we used a Gestalt model, and I don't know if I've got it here. Guess what? It's based on the cycle of experience. Mike Sturm was Gestalt trained. So what we did is we call it the modified cycle of work. The GISC model is a little bit more complicated, but similar to what Lynn talked about in her presentation, we did this first in 2 pilots. So the results actually sort of blew me away. And by the second pilot, they said, you've got to take this outside of medical services, and this has got to become the way that we work across the health system. And that's actually what they do. SCF also had the advantage of a very sophisticated data model. So they have been able to track this over time. So I couldn't find the per capita expenditure exactly, bringing it up to 2009 as the last data that I have. But what I will tell you is that the trend has continued. That in general, their patient population has grown 7%. Their expenses have grown at 2%. So after I finish, I'm going to weave a little bit of my personal story in here. After I came back from Alaska, was like, okay, what do I do? I expected everybody to just say, hey, here is the method. Let's all do it. And that wasn't the case. So I took some of that early time to create a relational leadership framework, competencies, and a curriculum. A wonderful provider worked closely with me. Just as I was finishing up that work, there's the chief relational evangelist, Dr. Andrew Morris Singer. He and I met each other, joined forces. Back then it was in primary care progress, and their focus was really very much advocacy. That's still an important part of their work, and it's actually a competency that got added to the relational framework. So what we did is launched this relational leadership curriculum. We created some leadership pathways. My history is I sort of get things started, hand it off, and move on. So I handed off the intellectual property to Intend Health, and stories like UNC, just you have no idea how much they warm my heart for somebody who is in the winter of their career and is interested in leaving a legacy. So today I continue to serve as a strategic advisor and a board member to Intend Health. So some of my interest has shifted from primary care to the rest of healthcare, and some of that is born out of, we call it the big sick, where my partner had some serious health issues, almost died, spent weeks on a ventilator. I call him the miracle man. But it's really just the reality of hospital-based care today. This comes from a Harvard Business Review article that's talking about reduced medical errors in hospitals. There has been so much time, effort, and money put into improving healthcare outcomes and quality. And the reality is that today, this gives me goosebumps. 1.2 million people are harmed each year because of medical errors. Health equity. The top 10% of hospitals are 10 times safer than the bottom 10. You're 2 times more likely to die in a poor performing hospital as in a high performing one. On average, it takes 17 years to implement evidence-based medicine, even though we know what it takes to make it work better. Healthcare leadership lags behind the rest of the industry by 10 to 15 years. And, in the business world, we've got culture eats strategy for lunch. Well, culture eats safety for lunch. And I'm going to talk a little bit more about that. These are just some of the statistics in terms of health consumption expenditures as a percent of GDP, medication and treatment errors compared to equivalent countries. Now we get to physician burnout. So upwards of 60% in some specialties, 50% of nurses are exhibiting signs of burnout, as are, this really scares me, 45 to 60% of medical students and residents. I cut my teeth in quality as well in manufacturing environments, and Ed Deming, quality guru, put a bad system against a good person and the system's going to win every time. And this is what's happening to well-intended providers. So the next time you get mad at your individual provider, this little circle in the middle with the individual, you can see how little impact they actually have on the system. So this is important as well, because just like mindsets need to shift, this goes back to the culture of safety. I'm not going to have you read all of this. I would suggest that you look at this study. But the bottom line is, if you look at this, this comes from Chris Argyris's work at Shines. We talk about espoused values and values as practiced. Well, here's what the values as practice say. Physician, clinician, we don't trust you. Your time isn't value. Money is more important than quality. We have made commodities out of patients, physicians, etc. The economics are more important than just about anything. From the provider perspective, there is this whole culture of perfectionism, and that your health outcome depends upon how skilled and perfect I am. So there's plenty of blame to go around in this, but and blame doesn't get us anywhere. The point I'm trying to make is that there are cultural shifts that need to be made at the individual, the group, and the organization. I love this chart, that this is what came out of the National Academy of Medicine. This is part of their plan. This is the first time that I have ever seen the true system mapped out. And notice that the health system is just part of it. It's the federal government, it's the insurer, it's health IT, it's specialty groups, it is academic institutions. So these are the people that need to get together, and what they've really done is mapped out the actors. So if I had my way, everyone would take 5 dynamics. And what you can really do is just substitute patient well-being. And this, to me, is where the transition is to teaming. I'm going to give you an example from Virginia Mason, Gary Kaplan, where they noticed in their spine center that it was expensive, their health outcomes were spotty, that wait times were long. So they put together a cross-functional team. They mapped things out, and what they found was variation in practice methodologies. That there was one group that really did advanced imaging. They did MRIs and that sort of thing right away. There were others that did PT. So what they looked at, they did research to say, where is the evidence about the best way to approach people who don't have complex back pain? Stanford actually had done a study and came out with the process, a protocol. The path was to do PT first if there were not complications. They implemented it and it worked beautifully. Wait times went up, outcomes improved, costs went down. But guess what? A few months later, they started losing money because they were reimbursed for doing imaging studies. Now, they were able to go back and renegotiate with their payers, but that's sort of crazy. It's not having the right people at the table. So some of my work right now is focusing on emerging leader development. And the reason that I think that the physician leader is important is one, they're the future, they're key stakeholders, and quite honestly, they've got a lot of learning to do. And I'll talk about some of the work that I'm doing there. Dyadic leadership development, where you've got physician leader partnered with an administrator business leader, and they are really partnered. They don't work in parallel. They are an interdependent team. And teaching, teaming, coaching leaders, and I think that the resilience and well-being work is important. And this is essentially where we need to go. So this last year, I did an emerging leader program with a multi-specialty practice. We had anesthesiologists, pathologists, orthopedists, etc. And guess what the foundation of the curriculum was? Very much what we did at the South Central Foundation. So we started with self-awareness. 5 dynamics had played a role. We also talked about interdisciplinary teams. So the feedback was actually amazing. So we just finished up that training in August. So there were 3 pathologists in that emerging leadership program. This is a division with 25 people. 5 dynamics had a profound impact, and it was about the individual, about how to use this with teams, but the process, it gave them a roadmap of how to proceed. So this division over the last, just think COVID, over the last year, they've lost 5 physicians. They've got a 2-week backlog currently, talking about moral injury. The burnout levels are high. They are at each other's throats. So based on the experience of these 3 leaders, they said, come work with us. So we've designed a retreat process. Who are we? What do we want? How do we get it? So the who are we part was just getting to know each other. Lynn talked about this with interdisciplinary teams, but we used 5 dynamics. And again, light bulbs go off on these for these folks once that they see, oh, we're not all the same. And oh, to maximize effectiveness, we need all of this. Like, wow, what a concept. So we are continue to work with them. The other, this work just came out, it's actually happening, unfolding as we speak, that the pathologists, because they're down 5 pathologists and behind so many weeks, they put in a request for an IT solution. The answer came down as no. The decision was made by administrators. No input from pathology. Talk about moral injury. So because the emerging leaders now had some skills, they didn't just move into the victim role mode. They actually have put together a little interdisciplinary team. And they called and said, can we do 5 dynamics for the entire team? They've got the team graph. They're going to use cycle of work as their methodology, and they're going back to the decision makers in January. Another example from anesthesia. This is an anesthesiologist who attended. Anesthesia has high turnover. They've got a hard time recruiting and retaining, particularly pediatric anesthesiologists. And this is, they have a large academic medical center, but also they cover rural areas. Pediatric anesthesiology is a subspecialty. So they were losing anesthesiologists in these community hospitals because they don't get enough practice. They don't have enough patients to make it worth their while. They've been asking to cohort the pediatric patients in ambulatory surgery since 2019, fell on deaf ears. Well, the anesthesiologists, once they got 5 dynamics, light bulb went off. We've got to include people. They formed a multidisciplinary team that included the surgeon, that included the clinic manager. So what they hadn't been able to do since 2019, they got done in months. So the expectation is that outcomes are going to be better, that physician satisfaction is going to be better, and costs are going to go down. And one more of when people don't use a tool like 5 dynamics. This is when I just got this call last week. It's a pediatric anesthesiologist, the ones that are really hard to get and retain. Well, the certified nurse anesthetists said, we're not going to work with her anymore. They have taken her off the service for a month. I'm going to work with her for a month to see if we can get it back on track. Lack of communication about care plans, defensive when CRNAs make practice recommendations, disrespectful of CRNAs. This is somebody who does not get interdependence. They don't understand that they are part of a team. So to me, the future of leveraging 5 dynamics is in these hospital systems. And I'm pleased that, you know, Lynn, you guys are doing the right thing, where you've got a platform where these groups can come together for short periods of time with a common language, a common process, a common understanding, create psychological safety, and get things done. You know, I say miles to go before we sleep in healthcare. So I'm sorry I went a little bit over, so I will stop here.
Well, thank you, Marianne. And for those that do have questions, you can either unmute yourself. This is just a regular Zoom, and you can go ahead and ask your question, or you can put it in the chat and I can reiterate it to Marianne. But I think for me, Marianne, clearly between, you know, kind of the approach to healthcare, and then you add the people, and then the process that kind of is interwoven throughout all those different elements. When you have one and not the other, can you still make advances, or is it the sum of all the parts that really is when the magic happens? Because I can appreciate where the approach might have financial constraints, the people piece might have cultural constraints, and how do you work through those to make progress?
You know, I'm a systems thinker, and one of the principles of systems thinking is what you do in one part of the system impacts every other part. Mm-hmm. So what you do at the individual, the team, and the organization level will make a difference. Now, having said that, I think that to really, you know, become the South Central Foundation, if you think about that map of actors, that those are the people who need to start to work together. But what they have done, when you think about teaming, people coming together, going apart, you can start with some of those teams. And for me, this emerging leader work is just so exciting, because when people get it, immediately they go out into their system. And Lynn talked about that some at UNC. That's what happened at the South Central Foundation. That's what happened at OHSU. So people are hungry for the relational side. It's a seamless braid. You need both.
Yeah, absolutely. So how do you approach the naysayers in terms of, whether it's there's another way, or I don't believe in this? And you kind of spoke to that at the last, with your last slide, which is there's consequences, right? I mean, there's palpable, quantitative consequences. But when someone kind of is rebutting kind of what you're advocating for, how do you kind of break through that, or how do you kind of reframe what that person is trying to kind of put in front of you?
So I think camp champions are important. The reality, we're all tribal. Physicians are tribal. If a physician says this is great, then it's great. If I say it's great, it's show me the papers, show me the evidence. So I think doing things like Intend Health are doing, I think the fact that Lynn is championing this work, I think that is critical. And I also, I respect cynicism. It's good examine energy. So with these pathologists that I work with, one of them, he was a good sport. He took 5D and he read the report first and said, "This nailed me." And then he said, "I'm still skeptical." But once he was willing to give it a shot in their pathology division, because things were so bad. And what he is now, he's gone from skeptic to hopeful.
Well, before you become an advocate, you have to be aware, you have to even consider it, and there's multiple steps. Typically, those that I think are maybe closer to themselves, are maybe closer to that light bulb moment that instantly translates to advocate, whereas others need to actually kind of see the proof is in the pudding in terms of the application of it, and have some wins, etc. So I don't disagree. Cynicism is all about having a diverse line of thought.
Yeah, and what I find is 5 dynamics does not generate the same resistance as some of the other psychometric instruments do, because it's not about their personality. It's about how they go about work. So I don't get the same level of defensiveness.
Yeah, well, in my own experience, both taking as well as applying 5 dynamics, I think I share that same sentiment. If anyone else wants to chime in with a question, you can either jump in and unmute. If you can't, for whatever reason, go ahead and put your question in the chat, and I'll just pause here to give a little space for that.
Is there a way we can see everybody?
I believe everyone's off camera, but we've got, and I'm kind of just looking at the chat, and I've got other questions too.
Okay, go ahead.
Marianne, it's Sarah Smithson. I have a question. Hey, Marianne. So one of the things I love about your relational leadership framework is that it really establishes relationships between individual people as the foundational building block to ultimately achieve systems level change, which helps it feel a little bit more achievable. And nevertheless, I couldn't help but feel like exactly the way you were feeling when you were like, I don't understand. It seems like the writing is on the wall. Why is this change taking so long? How do you stay motivated and keep doing this work in that context?
At times it's been a challenge. So one thing I do is actually, I started working outside of healthcare again. Just enough, because when I go to clients that are outside of healthcare, they value this work. They're happy to see me. They want me to come back. The other thing that motivates me is, this experience with pathology. Where 3 emerging leaders went through this program, got some light bulbs, and said, we're going to try some things. Would you help us? So that also gives me hope. This individual anesthesiologist that she's going to leave if she can't figure out how to work in this system. So it's not that hard to help her or him make that mindset shift. And once you do that, a whole world opens. People don't have to do it alone. It's that growth mindset versus the fixed mindset. And I think summits like this are really important because it's hard work. And without forums like this to recharge your battery, it really can get overwhelming. When I first saw that diagram, that network diagram, it's like, no wonder I'm exhausted.
Well, I think we can all agree that the federal government needs its own exercise in 5 dynamics to break through some of its malaise. But I think one of the things, Marianne, that going back to your example of Frank, and I think that was super compelling in terms of almost cause and effect, in terms of certain things that are interdependent, but ultimately are, kind of who he is and how that's influencing his health. One of the things I've always kind of been curious about is a lot of what you talked about is kind of within the hospital, meaning it's the process, it's the clinicians, it's all the different leaders that are part of that. But what if we actually knew Frank's 5 dynamics and how Frank likes to, take and receive information and piece them and give them the printout?
I am getting goosebumps. I've talked with Karen about this, that my dream.
Yeah.
So Central uses, they co-create. It's not a wellness plan with each customer owner. And wouldn't it be wonderful if that plan was printed out in their dynamics,
right,
and their integrated care team knew how to talk to them?
I mean, it's kind of one of those, like, maybe they don't have to fill out, and go through the assessment, but just ask them how they shop for groceries, right? Typically that's, a jumping off point to understand, oh, you just go and explore the apples? Great. Well, then let's just talk about all the different ways that this, topic might be.
But we're doing depression screens now,
right.
We're doing substance use screens. Why not do a how you learn screen?
Yeah. Well, and especially navigating, and not just for the patient, but the patient's family that also is obviously going through whatever event based on that diagnosis that they have to kind of manage through, because that impacts, sometimes the patient is quiet and the +1 or the partner is the one who's kind of quarterbacking the situation. And that obviously is all contextual for how you navigate that specific individual situation.
Yes.
Yeah, totally. Any other questions from the audience? Okay. Well, Marianne, thank you again for participating, but most importantly, your leadership clearly in this space, but in championing the power, whether it's a light bulb or whatever analogy is apropos to the situation. I think you're clearly demonstrating the art of the possible. And I think, to echo Sarah's comment, helping inspire others continue to push forward and making positive change. So thank you again for participating. And for those that are, I believe Susan's session is still going, but when you jump out of this one and you head back to the lobby, this is our last track of the day. So there is a short little survey right under the main lobby image. So would love to hear your comments and feedback. I definitely got an injection of Excite. I'm effortless plus when it comes to Excite, so that might make me abundant, but that's okay. But thank you all for your attendance. Again, Marianne, thank you so much for speaking and your leadership, and everyone have a good rest of your day.
Thank you all.
Cheers. Thank you.